thanks for coming. We are fortunate to have with us today Lisa Saldana as the Dissemination and Implementation Science Semester for the fall. And Lisa is a senior scientist at Oregon Central Learning Center, which is right down the road from us, which gives us opportunities to collaborate and work together. Her work is primarily in the areas of child welfare, juvenile justice, and substance abuse, and she's going to talk about some of those things today. She's been extensively funded through National Institute of Health, and she's also taken a leadership role in D&I work at the National Institute of Health, both serving on the DNRH committee, which reviews the D&I proposals. She's a standing member on that committee. She's also taken a significant role in training and mentoring faculty who are interested in coming through and learning more about the field. So with that, I'd like you to join me in welcoming Mrs. Saldana.
Thank you. Thank you, guys, and thank you for inviting me. So I'm going to today take a little bit of a slight different angle, and I'm going to be talking about some measurement development work that I have done in the D&I space and how that applies more broadly to interventions outside of my own, but more to interventions in the real world setting, community practice settings internationally. And so I'll take a little bit where we're going to just do a couple of, just so we can get on the same page around what we're talking about. We spent some time at lunch just now talking about how semantics are sometimes some of the biggest barriers that we encounter in this space. And so I'll just do a little bit of introduction and then lead very quickly into the development of the measure, how it is that we think that impacts implementation fidelity, and then how that drives different decisions around implementing in real world settings, so outside of the kind of ivory tower settings. So to begin with, I just want to thank my funders. And so as Peggy generously mentioned at the beginning, I'm primarily funded by NIH. And this work that I'm going to be talking about specifically began under funding that was given to Patty Chamberlain, and then I've taken over myself. So thank you to the SIC team. So this is the team that has helped with all the analyses that I'm going to be presenting today. And so it is a large team, even though it's a small little measure. So to begin with, talking about implementation. So I know that everybody here in the room has an idea about what dissemination and implementation means and is, or else you probably wouldn't be sitting here. But I wanted to make sure that we had a few distinctions because this really drives the work that I do. So when we think about diffusion, we think about that, are folks familiar with Rogers' theory of diffusion? So one of the real, foundational core pieces of work for this field overall. But when we talk about diffusion, really what we're talking about is we're talking about where you have such a good idea that this idea gets taken up or gets adopted with relatively little push that is needed. So an example of this that we like to give oftentimes with the folks that I work with is Apple products. So there is the iPhone. The new iPhone comes out. Everybody hears about it. There's, of course, some marketing that takes place, but really there's a lot of hype. The product in and of itself generates the hype. And so folks want to have that. They want to be early adopters. They want to be known as early adopters of that particular product. So that's what we think about when we think about diffusion. When we're thinking about dissemination, we're thinking about delivering information and hoping that in the delivery of that information, that in and of itself is powerful enough that folks are going to be interested and motivated to adopt whatever it is that we're talking about. However, when we think about healthcare, that very rarely happens. It's very rare that somebody says, wow, I want to be an early adopter of this new particular healthcare intervention. And oftentimes, same thing, we might read an article, we hear on the news, we hear this information about new healthcare practices that are being disseminated to the field. But again, that's not enough for folks to really have a public health impact where you start to adopt those new practices. So implementation itself, which is the space that I work in, is really what does it take to make it happen? How do we go beyond having the cool idea? How do we go beyond telling people about it? And what is it that we have to do to become really active in that process to facilitate the adoption of these new practices? So when we think about implementation again, it used to be that we thought, well, we've got this really cool idea and it's just going to end up in practice. I've got this idea, I've tested it, it's amazing, it works, so we're going to find it in our local doctor's office. Well, what we then thought was, well, maybe there are a little bit more ups and downs. Maybe that's why people aren't actually adopting it. Maybe because there are these, you have these barriers that you encounter, but then you get over the hump and then it's going to be adopted. Well, we've now since learned that that's not the case either. Instead, the journey is much more recursive, backwards, forwards, ups, downs, pretty unpredictable at times, feeling really chaotic. And at any point in time, this particular journey, we can experience a sever, right? We can experience a stop in that journey. And then where it picks up again might not be on that same line. And so that, when we're thinking about how do you measure implementation process and how do you work knowing that this is sort of the path that we are dealing with, that's what my work is focused on, is how do we really operationalize this path and how do we put some standardization to it so that we can start to predict what it takes to increase sustainable outcomes. So the work that I do really focuses on the full implementation process. So I realize the font is really small. The intention is not for you to be able to read this figure entirely, but this is the original version of the EPIS model, which is exploration, preparation, implementation, and sustainment. This is done by Greg Ahrens and colleagues. And Greg and his group worked alongside the SICK team in my group. We were working in parallel with one another at the same time and are fortunate enough that we are close collaborators. And so the work that I do really spans this full implementation continuum. And so that's what the point of showing this is so again, we're on the same page. Oftentimes when people think about implementation, they think about it starting right here at the active implementation phase, which is where you start training, you have your workforce in place, and you start to deliver whatever it is that innovation is. What I'm suggesting is that we need to back that up. And again, using this full spectrum of implementation, that's what I measure, and that is where we have found that we've got some, what I hope you will find interesting outcomes to share with you. Another thing to keep in mind is who is involved. So in this implementation journey, oftentimes we think about it as being a very linear process. And so it starts with your developers, they develop an intervention, they test it out, they find that it's effective. Then that moves on to your purveyor group, who are the ones that are disseminating this out into the world. You have your system leaders, your agency leadership, et cetera, who are all involved in the process. And so again, when you're thinking about measuring implementation process and thinking about how do you facilitate this into the real world, we aren't just focused on just the developers or just the practitioner providers or even just the clients. Every single one of these individuals are key to have a successful implementation process. However, everything that I just showed you looks really linear. And if you think back to the very curvy nature of what we were talking about before, we know that implementation actually entails not just this recursive process, but it's dynamic with lots of interactions. And all of those agents that I just showed you in that very nice straight line, those folks are not all equally involved at different points in time. Obviously, they have come with different agendas. And so our goal, again, of measuring implementation process is how do we capture that? Because in reality, in the real world, it looks more something like this, where who is important changes over time. And so if you could think about this as not being stagnant, but the names of the individuals might be standard, but then the spokes around it are changing constantly. The cogs are changing. And so a program program champion might be really important at this point in the implementation, but then might be far less important at the point that maybe the client-patient level is more important. It really depends on what it is that we are implementing, but the point is that this is a very dynamic process. And so again, when measuring that, how do we do that? So for myself, decided to sort of think back, well, what can we learn from the original literature when it comes to developing interventions? And so are folks familiar with this graphic? Have you guys seen this? This is something that, so this is Hendricks Brown and a whole list, I'm not exaggerating, probably like 20 authors on this particular publication, put together this about 2 years ago, 2017. And so what you see on the left-hand side here is you see the typical journey for intervention development. And so first we do our pilot studies, our feasibility studies, then we do our efficacy studies where we as the developers are still very much hands-on. We move it into our effectiveness trials to see, does this work out when I'm not as involved anymore? Well, how did we start to learn about how we made it from the coulda program work to making a program work? That was really about fidelity. Learning what does it take, what are the true components of an intervention that we have to hold true to in order to achieve those outcomes in the real world. If you look here on the right-hand side, this is again that EPIS model, but now this is in the D&I space. So after we have an intervention that's proven to be effective or demonstrated effectiveness in certain contexts, how do we then implement it and get it out there? And what I would like to suggest is that we could still learn with those same principles of fidelity. And that's really what I'm going to focus on for the rest of our talk that we're talking about here today, is how can we make those same similarities? Because can we then move just the same way that we move from the intervention trials in the implementation trials from exploration, preparation, implementation to sustainment? So my own personal goal is that I am interested in developing sustainable programs out in the real world and helping folks implement their programs in a sustainable way. The primary reason being because of wasted resources. So what happens is that we go into communities, we implement these programs, and they invest a lot of their own resources, non-grant funded resources, into adopting these programs. If we do not sustain them, particularly for our most vulnerable communities and most vulnerable populations, those are resources that are now wasted that could have gone someplace else. Worse yet, those are some communities that might be reluctant to adopt evidence-based practice again if they feel like somebody came in, implemented something, and then took it away. So my whole goal is how do we develop sustainable programs? So when we think about fidelity, are folks in the room here, are you familiar with the concepts of fidelity? So I'll go through this pretty quickly. I see some people saying no, but most people saying yes. But I will go through this. So in order to achieve intervention outcomes, what we think is we think about you want to adhere to the key components of the treatment, and you want to deliver those components well with competence. And that is how we say that we establish and obtain our treatment integrity. And so this is what we think about for intervention fidelity. And I'm going to give you just a quick example of this. So when we're thinking about fidelity, really those core components need to map onto the mechanisms of action. That is what makes that intervention work. And we're going to be talking about this in parallel with implementation in just a second. So what is it that makes an intervention work? And I'm going to get, so from our work at OSLC, there is one particular evidence-based practice called Treatment Foster Care Oregon. I'm not going to go into huge detail other than to say that this is a very complicated evidence-based practice for youth involved in the foster care system. And some of them are there because of child welfare issues, some of them are there for JJ issues, and some of them are there because of both, dually involved systems. So these are families that are highly vulnerable, system involved, and yet backed by multiple randomized trials, this particular intervention, TFCO, demonstrates that families and youth that are, that are randomized to TFCO, they fare better than those that don't. Now, what are what drives these outcomes, though? These are the mechanisms. So the mediators. So the mediators are supervision, relationship with mentoring adult, non-harsh discipline, less associated with delinquent peers, and homework completion. So this is not huge rocket science. So we're treating this very complex problem in these very complex systems, but ultimately the mechanisms of action of the intervention themselves are ones that we see across a whole bunch of different parenting interventions, right? So that is what we really want to hold true to from an intervention standpoint. How do we get there? Well, the way that we get there is going to vary depending on the context that we are living in, right? And so what we know is that we need to provide close support to foster parents. We need to tailor the interventions. There needs to be daily monitoring, things like this. So these are non-negotiable. These are different ways to accomplish those mechanisms, but how we do it might really differ depending on the communities that we live in. So one example that I often give is around the idea of supervision. So for TFCO, a youth is not supposed to ever be outside of sight of their caregiver. Well, there are many TFCO programs in New York City right now. How do they do that? Well, we had to modify how we basically monitor kids on either end of their subway stops, right? And so that is something, it doesn't mean that the model itself has been adapted. It doesn't mean that we are changing the mechanisms of action. It means that how we do it, how we get there, varies because of the context. So think about that, because we're going to keep those same idea in mind when we think again about implementation. Because now when we think about implementation fidelity, most often if you go to the literature and you look for this, what you're going to find is you're going to find something around a particular strategy, an implementation strategy. So for instance, coaching is one that's frequently cited in the literature. And so that is one strategy that is there to help with implementation fidelity of these particular intervention components. What I'm talking about is going back to that full span of what we mean from implementation. So when I'm talking about implementation fidelity, I'm talking from the exploration all the way to the sustainment phases. And the goal then is that how can we perform implementation activities again with that same idea of adherence and competence, but now it's to achieve positive implementation outcomes. We're assuming that the clinical interventions are effective because we are implementing evidence-based practices. So now we have to ask ourselves then, okay, using that same frame, what are the mechanisms of action for implementation then? And what are the things that we want to keep in mind from an implementation, the work I do, process evaluation part of it? So this brings us to the 6, so the stages of implementation completion. So this was developed, I was at the right place at the right time. I do not want to take credit for this idea. I just happened to land at OSLC right when Patty Chamberlain had the first NIH D&I project that was funded. So it was under the very first cycle of D&I funding. And they had proposed for this model that I just went through with you, TFCO, a head-to-head trial of implementing TFCO throughout California and Ohio, but doing it under 2 different implementation approaches to understand whether or not one approach would be more effective than others. They were going into communities that were non-early adopting communities. So those 2 states had been offered TFCO in advance, and some counties did sign on, but many counties did not. So the goal of this project was to understand how can we implement this complicated intervention in non-early adopting counties where a need had been identified by the state, but the counties themselves were not signing on. So I'd love to talk to you guys about that project, but that's not what I'm focused on, is that I happen to be, again, right place, right time, and charged with how are we going to evaluate our primary outcome? Because at that point in time, we didn't have a way of measuring implementation process or the different strategies that go into implementation approaches. So I had the serendipitous opportunity to just sort of observe all of these different counties and see what did they do if left to their own devices, and then how did they start to respond when we started to impose different implementation strategies on them. So in that, we started off, I was able to measure what are these different activities that they're doing, what are the different activities that are looking like they're being helpful. And we developed this, originally it was 15 stage, then, psychometrics, it went to 12 stages, then 10 stages, and now we're at 8 stages of implementation. It is a date-driven measure because what we are looking at is we're looking at proportion as well as duration, because again, the non-linear recursive process of implementation. And we found that it spans 3 phases of implementation: pre-implementation, implementation, and sustainment. So this maps on directly to that EPIS model, with the caveat that the first 2 phases of the EPIS model, when we look at them psychometrically, hang together to create pre-implementation. So pre-implementation in my language is the same as exploration and preparation in the EPIS framework. So these are our 8 stages. Again, I'm going to qualify this to say none of what I'm going to tell you is rocket science, okay? This is all stuff that some things you might be able to kind of guess from your own experiences, but what this is allowing us to do is to start to put data to different situations and different contexts so that that can help ideally inform the future work that we do. So the 8 stages that we have 3 stages in pre-implementation, we have 4 stages in implementation, and then so far we have this one stage, stage 8, that I view as the doors opening to sustainment. We obviously know that sustainment is a lot more than just achieving competency. I have current active funding right now where we are exploring what those future stages would look like. So we call them stages 9+, because we don't know how many stages we're going to end up with. And then you can see on the right-hand side here, these are different agents that are involved along the process. Now, these are just examples. This might change, again, depending on what it is that you're implementing. But what the point is that if we're implementing in the real world in communities, you can see how system leaders are very actively involved during the pre-implementation phase. When you're actually boots on the ground implementing, they're less important when it comes to actually being successful with your implementation, but look, they pop back up when it comes to achieving sustainability, right, and sustainment. And so that's where, again, there's that dynamic nature of different agents have different value throughout the implementation process, which makes it, again, challenging to measure. So within each of these 8 stages, we have multiple activities, implementation activities, many of which you might recognize from, for instance, the ERIC implementation strategies, if you guys are familiar with that work from Byron Powell. And so these are just examples here. So in each of the stages, again, it's date activities. So we have like the date that a home visitor workshop might be completed if we are in stage 4, which is around hiring and training. In stage 5, for this particular one, is the date that trained on the dashboard entry use. So this is their Fidelity monitoring tool. And so within each of the stages, multiple activities. And these different activities, the idea is that the stages themselves are standardized across the different programs, but the activities are customized to whatever it is that you are implementing. So for instance, this says home visitor workshop, but somebody else might, call it a, whatever, their community partner training, et cetera, et cetera. It just depends on what it is that you're implementing. So the SIC has 3 scores: your duration score, how long does it take for you to complete these activities, the proportion of activities that have been completed, and then your final stage score, how far along did you get in the implementation process. These are all calculated at the stage level as well as the phase level. And most of the analyses that I'm going to show you today are at the phase level because that's where we have greater power. One thing that's really important, and we learned this the hard way, so if you were to go and look at some of our early publications on the SIC, we do not talk about missing data this way. We learned, this was part of our evolution of the SIC, is that all missing data is not created equal. So when a community agency or a system fails to complete a recommended implementation activity, it's incredibly important to find out why. Again, going back to that idea of resource use, if they are not completing an activity because they've already completed it for a previous implementation of a different innovation, that would be wasted resources for them to repeat that activity again. So we don't like to now new version of us, a few years old, we wouldn't want to count that as missing. We instead will now call that expansion activity. So this means that they are expanding off of previous implementations that they have done. Something could truly not be completed, and that's where we find a lot of our variability. That's what we want to be able to distinguish. But then also sometimes things aren't completed because it's not applicable for that particular community. This particularly comes in when we're looking at the difference between interventions that are being implemented, for instance, in rural versus urban environments. There are some things that just aren't applicable. And then, very importantly, we have data that is missing, not because it's actually missing. We know that it happened. We just don't know when it happened. And we do not want to, our modeling was off when we were recognizing that there were teams that were being successful, but they had a bunch of missing data, but then we found out the data is not actually missing. They just didn't have a date to attach to it. And so when we include this missing data type, what it does is that impacts our ability to calculate the duration scores, but it does not impact our ability to calculate the proportion scores. And as you'll see in a few slides, that's an important distinguish. So we started off, again, creating the SIC for that one particular research project with TFCO. And then since then, because there was this lack of a standardized measure of process in the field, the SIC very quickly kind of took on a life of its own. And so I was able to secure some additional funding. And so my first RO1 actually was looking at the SIC and how is it that we can conduct adaptations for different implementations in different service sectors serving different populations, to determine, is there actually a measure of implementation fidelity that we can find from this? Are there standardized ways that we can start to inform implementation more broadly? So we have this adaptation process that is now a standardized process. It's very collaborative. It's an iterative process. I go and I get to know the developer or the purveyor group of these particular, sometimes it's an EBP, sometimes it's an initiative, sometimes it's a policy that they're trying to implement. And so go get to know them, understand their what it is from their perspectives they feel like needs to be accomplished in order to implement well, and then do some observation of what has worked for them in the past, what hasn't worked in the past, understand the data sources that are available to them. And in this process, we then develop a SIC for them. So there are two different things, and I'm going to talk first, what I'm talking about right now is the adaptation process. So this is where each and every item on the SIC is really customized or adapted for that particular intervention. Again, the 8 stages stay the same, but those activities are different or tailored to that intervention. So we have done this for over 20 different practices. This is an example, or this is a list of them just to show it's across different service sectors. We've got child welfare, we've got schools, we've got primary care, international, different EVPs that we're working with. And by and large, the summary of applications that have been replicated now is that the SIC is able to reliably distinguish good from poor performers. We can reliably distinguish implementation strategies, pre-implementation, so those first 3 stages, predict successful program startup or program launch, serving your first client. It also predicts discontinuing of programs, and then not surprisingly, the combination of pre-implementation and implementation predict development of competency. So this is across these adapted 6 that we've been able to replicate. One of the things, though, that I have found, and again, I'll show you some data to support this, is that, and it sounds kind of callous, but I think it's something for us to keep in mind when I think about the larger goal, is that it is it's not easy, but it is easier to start a program, to launch a program, to get a program on the ground. It is much harder to get to the point where that program has been sustained. So through these different adaptations that we have done, what we found is that these different, it was again, back to this issue of semantics we were talking about at lunch. Oftentimes what we found is that these implementation approaches that these different developers were coming up with, regardless of service sector and regardless of population, were more similar than not. And so we might be using different words. I might be saying I'm going to train a consultant, and you say I'm training a manager, and you say I'm training a supervisor. We are all training somebody in a leadership position who is heading a team. And so if we step outside of the actual words and look at the meaning behind each of the things that we were looking at for implementation activities, we went ahead and we conducted an independent, rigorous reliability exercise and found that, yes, there were more similarities than not. We landed on 46 different activities that were common across all of these different implementations, regardless of what it is that they were implementing. So 46 items, some of the adaptations that we have done are nearing about 200 items of implementation that they are requiring or that they think are necessary from their community partners to be able to implement their intervention. If we can boil it down to 46 items, that becomes something that we can coach to. That becomes something where we can start looking at how much resource goes into each of these individual activities. And we can start thinking about, again, a measure of general standardized implementation fidelity. So the numbers over here are the number of items that on each of the different stages. And so you can see, not surprisingly, that readiness planning, stage 3 has 10 items, and then ongoing service delivery. So where you really, again, have your boots on the ground and you're delivering the healthcare innovation, that we have more activities in each of those 2 stages. So does this work, though, in terms of, like, is it psychometrically sound? So again, reminding you that this is a date-driven measure. We aren't able to use our typical psychometric analyses. Instead, we used Rush modeling. So using this IRT method, what we were able to find is that, yes, indeed, these 46 items, to use the old psychometric language, they hang together in these 3 different phases, as we would hope. And we have good reliability and separation between the different items. So we were confident that this is a strong measure. But what we wanted to know is, but does it have the same predictive utility as as the more tailored, longer 6? Are we still able to predict those successful outcomes? And what we found then, so this is in pre-implementation, is yes, there's a high degree of correlation of the predictive ability when we're looking at it from an individually tailored versus when we're looking at it from these universal items, is what we've been calling them, the universal 6. And then we see the same thing for implementation. In fact, it's even more highly correlated. So this, again, gives us confidence that, yes, we could start thinking about this as a measure of implementation fidelity. Again, not for you to look at, but this is the actual measure. So these are the 46 items. So you can kind of get a sense of, this is by stage, how it kind of shakes down. So none of the stages are incredibly long, and these are the general just definitions. And again, I'm happy to share this with anybody. This is not for you to be able to see. It was just more a demonstration. So these are the different service sectors that we now have Universal 6 in. And so what I'm about to show you then is now using these different both adaptations, so those 20 plus adaptations that we've done, but then also these customizations that we've done. So this is the difference, is that now what we get is we get folks saying, hey, we want to use the universal SIC. And so what we do is we customize the items. The items are exactly the same across these different initiatives, but what's different is the language, so that if you use supervisor and I use manager, we have it so that for data collection purposes, you are able to map this on well to the intervention that you are trying to implement. So with that now, I'm going to show you data from a little bit fewer, but we are tracking nearly 1,800 implementations worldwide. And so this is what the SIC looks like. This is a graphic that we have modified from SAMHSA. We used to be, when SAMHSA had INRUP, are you guys familiar with INRUP? INRUP got defunded. Anyway, it's a National Registry of Evidence-Based Practice. So the SIC was a framework on that website, and they had a graphic that was similar to this that we kind of stole when they went under. About what we found, so following 1,481 sites, of those 63%, so this is again worldwide now, 63% have discontinued. So we see the majority of implementations worldwide that are taking place using these different models, that the majority discontinue. And the majority do so in pre-implementation. So 85% discontinue in the pre-implementation phase. Right? So when they're engaging, when they're determining whether it's feasible, when they're determining whether or not they're ready to do this. So on the one hand, we can say, well, that's good. They're quitting and getting out before they're wasting too many resources. On the other hand, they wouldn't be looking at these evidence-based practices if there wasn't a need. So that means that there is a need in these populations that these particular practices might be able to fill, that for whatever reason, we are not able to get those programs to the point of being able to launch. When we look at those who do make it through pre-implementation, so 39% make it through pre-implementation, so we've cut that sample way down, but if we limit it just to those, then we see that 77% start a program, but only 31% actually sustain the program. So we've cut our sample in half, cut it down again, cut it down again. We're talking about a very few number that actually obtain sustainable programs. In the light green, which I realize is hard to see sorry about that, but what I was showing is this is from the original 1,481. So if we look at our full total sample, that means that 30% are launching a program and only 12% are developing a competent program. So we have a long ways to go. So how can we use this information to help us get there? So if we think about stage 1, these are the 4 standardized activities from the universal SIC from stage 1. It's really around engaging. And so that seems like something that's pretty simple. However, this is, I'm going to show you some quotes from a paper from Aram Nadim, who did a implementation using the SIC of CBITCH, which is an intervention for trauma in the schools throughout the New York City school districts. So in that, what she found was that of those that were successful implementers, they were more thoughtful and more involved in their process. They took longer. So they involved more people in this. So saying that they went and they signed off with bills, with invoices, they involved more people. It was the medical director, it was vice president, community services, involving community partners in this decision in these particular schools. Versus the schools that were not successful, they were quick and they involved fewer people in the decision. It was more top down. It was basically a single administrator had a conversation, they made a decision, they decided to move forward. So they aren't spending very long and they aren't being very thoughtful in the engagement. Now, across all, again, this is our 1,481, what do we find? Is that even if this is proportion of activities completed, if you complete 100% of your engagement activities, you still only have less than a 50% chance that you're going to develop a program. So that lets us know that engaging alone is not enough. Again, not rocket science. However, not rocket science to us now. 10 years ago, we used to think if they raised their hands and if a community said, I want this intervention, that should be enough. So now we have data to suggest even if they do that well, that's not going to be enough. So then if we look into consideration of feasibility, again, back to its just core essence, these are the 4 sort of core feasibility activities that shook out. And so you're basically determining, is this feasible for us to do in our particular community? And again, from the same school-based study, we have our successful implementers who said that they made a commitment, that they were looking at being flexible, They had run similar programs before. They knew what it was going to take. They knew who they needed to have involved. And so they had a really good sense of whether or not this was going to be feasible within their schools versus those non-successful schools where basically they said, you know, you guys are the experts on your own schools. You figure it out. You can do it. And so it was more of a cheerleading approach as opposed to actually determining whether or not it was feasible. And there were also issues of not being able to, you know, like there were barriers, but they weren't able to like really problem solve the barriers, et cetera, et cetera. So again, not being really feasible. But then what do we see here? So we see that feasibility is far more important. So assessing your feasibility is far more important than engagement. And yet, if we look at our data, oftentimes folks ignore this piece. They go from engagement right to readiness, and they aren't really looking to see, is it going to be feasible for us to be able to do this here? And if it's not, what can we do to make it feasible? So taking the time and problem solving that is something that gets overlooked quite a bit. And now if we look at readiness planning, so readiness again you hear a lot about it. It's kind of a catchy buzz thing right now. Everybody's talking about readiness, but folks don't really know what goes into readiness and what it entails. And so these are our 10 items that are from our measure. And basically what you see is that this is where you start to get into your nuts and bolts. And so this is where you're determining, can we afford this? We have to do like capacity analyses. This is where you're involving your stakeholders, making sure you've got stakeholders involved, determining who the most appropriate service providers are. They aren't always who you think it's going to be at the beginning of your implementation, et cetera, et cetera. So really these nuts and bolts. And again, if we look at this then, we see that those that are successful, again, they are handling this with a lot more precision. They're being very deliberate in the decision making, involving a bunch of different people again, and really having champions who are spearheading this in those different schools that they're in New York. And so people that were taking it on and were really giving this the energy and effort that it needed versus those that were non-successful. They're saying, like, yeah, there really wasn't much meeting in terms of after we decided that we were going to go, we were going to go. The reason why I put this one quote here about our larger agency does not allow us to bill for groups, actually they did. They just didn't figure that out during the readiness process. And so this particular school failed in the implementation because of an inability to do something that they actually had the ability to do. They hadn't worked that out. So those are, again, the sorts of things when we're talking about readiness. And then when we see here, we see that you start to get a much bigger bang for your buck when you're talking about including these readiness activities. So here you can see that you have a greater chance, a probability of being successful. And you see that you start to achieve that a little bit closer in with, so you have to do less and you get more when it comes to your readiness activities. So just showing some statistics real quickly. So the role then of proportion in these predictions that I just showed you. So you can see that across, each of the stages individually. So reached program startup is one of the endpoints, and then known in status. Known in status means that they had the opportunity to make it to sustainment, and they either did or they didn't, but they had that opportunity. So across both of those conditions, we see that proportion, the role of proportion, is statistically significant. When we look and we put them all three of the stages in the model together, still remains significant for reaching program startup. But when we limit that then to whether or not they had the opportunity to achieve competence, we see that stage 3, so readiness, is where it's at. That's where we end up getting our biggest bang for our buck, is with readiness. So what about duration though? So what this shows you here, this is from a small subsample of sites, and the green line are those that are certified. So those are the sites that reach and enter into sustainment versus those that discontinue. All of these sites made it through pre-implementation. Every single one of these sites launched a program. So these are programs that launched, but then the ones that made it to sustainment, you can see they did in between each of their implementation activities, they did it more quickly, more rapidly. So they did the same number of activities, but they did it more efficiently. They were more resource efficient in the way that they did their implementation. And so now duration doesn't matter. So what we see here, again, I know a lot of information, but here your proportion, if it's in the model alone, just like we just saw, not surprisingly, yes, it's significant. If we look at duration alone, yes, it is significant. When we put them both into the model together, though, what do we see? We see that duration loses its significance, and really this model is driven by proportion. This does not mean that duration does not have any role whatsoever. It means, though, that again, when I was talking before about that missing data, that's why it's really important for us to include those missing data parts, because the proportion is what's going to give us the strongest indicator. And if you have to make a choice, then I would take longer, even if it's outside of the recommended amount of time, to be able to do all of your activities. So this again goes not unlike the treatment intervention development literature, adherence, incompetence, but you have to have what's on your adherence checklist, and you have to do that well. But it's better to do all those things on that adherence checklist than to not do them at all. And so it's sort of the same message here, but for implementation. So what this I'm going to show you is that the role of duration, what we see is that it's really most important. So here is phase 1 proportion down here. Really where it matters the most is if you do all of your proportion activities, so the red is a bad duration. If you do all of your activities, it doesn't really matter. If you don't do any of your activities, it doesn't really matter. Duration plays the biggest or shows the biggest impact for these in-betweeners, which of course is where most of our community agencies sit, right? They're not doing everything and they're not doing nothing. They're doing what they are able to do in between. So this lets us know we do need to pay attention to duration when it comes to those in-between types of agencies. So why then are we emphasizing pre-implementation if it has not become apparent so far? It's because really that's where I feel like we have the greatest chance to move the needle when it comes to successful implementations. And so this is some very, very recent, you guys are only the second group to see this, this graph. What you see here is this basically, each line represents proportion of implementation activities that have taken place. This is phase 2 proportion on the bottom. This is phase 1 proportion. Essentially what this graph is showing you, to cut to the chase, I know there's a lot of information here, is you can do the most perfect implementation. So you start from training, you hire the best people, you train them excellently, you implement well to fidelity of that intervention. If you have not done a good job with your pre-implementation, you still don't sustain. And that to us has been both what we've expected, but also is really disheartening when we think about how much folks forget about that pre-implementation stage or stages. And so that means that even the best intervention, if we skip that bit, we aren't going to make it to successful implementation. So we've used this information then in my own, and I'm happy to discuss this further afterwards because I'm not going to go into detail here. But so using this information, this is what I've now been using and my colleagues have been using as we do our own. So I also am an intervention developer. So this is how we implement our stuff worldwide. So I have used this now. R3, Ryan here is using R3 for his dissertation. We've implemented successfully throughout New York, throughout Tennessee, and we now are implementing it here in Oregon, and we're using the SICK as our implementation approach. TFCO, that first model that this was built with, the purveyor organization has completely revamped their implementation strategies, and they now are using the SICK to inform the way that they purvey or the way that they deliver. KEEP, which is a foster care implementation that Patty Chamberlain developed also, They use the stick internationally. I'm partnering with the government of Australia. They're doing system reformation across multiple systems, and they're using the stick for their implementations there. And then we just now have received last week funding to implement FAIR, which is an intervention that I developed for substance use here throughout Oregon. And we have a FAIR SIC that we are using with the state. And we started those procedures just 2 days ago to start using the SIC statewide to implement FAIR. So take-home messages are basically, we believe and feel confident that this can be used as a measure of implementation fidelity. That obviously successful sites can be identified based off of this pre-implementation behavior and in the standardized objective way. Just like from intervention development, that we have adherence that drives probability, drives success, but duration also is important. And you can go too fast, you can go too slow. We need to find the sweet spot in the middle. That quality implementation can ideally help to reduce unnecessary adaptations. If you do a good, strong pre-implementation, we have found that the need to actually adapt the interventions are reduced because you work those things out during your pre-implementation process. And then, as I mentioned before, we have current work going on where we're now looking at the SIC as a prospective, facilitative SIC coaching model to see, and we're doing randomization of different teams to see whether or not using this in a prospective way to provide information to agencies can help train them to implementation fidelity. Of course, we want to consider sustainment from the get-go. Everybody has to be competent before they can sustain, so we want to do what it takes to reach competency. Obviously, pre-implementation, as I was talking about before, is particularly relevant. Duration is more important in pre-imp than it is in implementation. And if you have to make a choice, choose adherence over duration. And then finally, really, this is a charge to, I would say, institutions, to funders, to federal level, state level, is that timelines need to account for pre-implementation. Oftentimes we don't get funded to do that. What happens is that you get your grant and they say, we want you to start seeing clients or patients in the next month, 2 months. And what our work shows is that if we do that, then again, that's going to be wasted funding resources and potentially engender some reluctance in the communities that we're working with. So what I've been doing lately is going around to different funders and like CDC, NIH, and really trying to advocate for within their funding announcements to provide some opportunity for us to do good quality pre-implementation. And then finally, what we all know, train and pray does not work. And so we can't just start where we're hiring and training folks, but we really do need to sort of honor what goes into pre-implementation and give it the time that it deserves. So thank you. So we have about, looks like 10 minutes, a little less than 10 minutes for questions. Yeah. Anyone?
Can you talk a little bit about whether or not you looked at funding issues around any of these aspects of SIC?
Yeah, that's a good question. So the short answer is no. The longer answer is we're in the process of doing that. So what I didn't show here is that for the SIC now, in its more recent versions, I would say probably the last 5 years or so, we've been collecting organizational demographic data of all of the agencies that we have been tracking. And so one of the questions that we have on there is around funding. And so we'll be able to look at that, but we haven't. Yeah. We, of course, hear, I mean, like from our mixed methods work, we hear all the time that funding is one of the most significant barriers. But again, that would be something that ideally in readiness in stage 3, you are spending time thinking about. We have, I didn't talk about here, there's an adjunct tool to SIC called COINS, which stands for Cost of Implementing New Strategies. And so what we do is we actually are looking at both like human resources, so like number of hours, as well as direct and indirect costs for completing implementation activities. And so in that, we are able to also answer that question a little bit more. Yeah.
Just to speak on your last point, how receptive have funding agencies been to advocating for the pre-implementation, and what do you think it will take to get more buy-in?
It's a great question, and I would say that this is purely my own anecdotal, so this is just my own perspective, is that it seems to me that program officers and the folks that are working directly with the scientists are aware of the problem, acknowledge the problem, and are trying to advocate for it. The folks that make the decisions about how much money goes into where and what, that's a little bit of a tougher nut to crack. Yeah, yeah. Yeah.
You talk about this issue of semantics a good bit, and I kind of heard you interchange maybe purposefully this idea of customization and adaptation.
Yes.
And if you could maybe just speak to that a little bit more. They almost feel synonymous, but clearly there's some distinct difference in the SICK model.
Yeah, so yes. So adaptation is, I view for adaptation, both for implementation, but also for intervention, is where you actually are looking a little bit more at changing those mechanisms and specifying for that particular intervention what the needs are. And so in the SICK model, when we say customization, we mean that you're using the universal SICK items. So you're sticking with those 46 standardized items, and those don't move. Those are the same items. We just customize the language to map onto your language, but the items don't change. Whereas an adapted SICK, we build from the ground up. With only the 8 stages as sort of our skeleton. We actually call it the skeletal SICK. And so that's sort of the structure that we're operating under. But what goes into each of those 8 stages is an unknown until we're done with that process. Yeah.
Could you talk a little bit about the opportunities to work in this field for people who either have been in related fields and are interested in implementation science, or for students who are, getting their graduate degree and thinking about what's out there for them?
Yeah. So I think more and more there are different institutions that are developing programs of emphasis, both at the undergraduate, but more often at the graduate level, focused on D&I. And so I think you guys have some work going on here. There, other institutions have full-on implementation tracks and D&I tracks that they are focusing on, so you can look for those. But in our regular sort of day-to-day, NIH has TIDER, which is the training in dissemination, implementation, research, and health. And then there's a specific TIDER for cancer. And then there's also IRI, which is the Implementation Research Institute, which is run out of WashU. And that is a 2-year fellowship program in implementation science. That one is focused more on early career folks. And so to be an IRI fellow, you have to have experience with funding, but not have had an R01 yet. Whereas for TIDER, TIDER is open to a range of anybody depending on where you are in your development. But if you're wanting to make the shift from whatever your discipline is to implementation science. And so those are some opportunities there. In terms of locally, I was talking with Peggy here that I would love to have folks, if you're interested in learning more or dabbling or deciding whether or not this is an area that you'd like to go into. I would love to talk to folks, and I would love to entertain the opportunity for people to come and see our shop or work with us. We have more data than we know what to do with. We have so many analyses that we want to run that we simply don't have time to run. And so there are lots of opportunities for local collaboration as well. So I don't know if that answers the question. Oh, funding.
Research funding.
Yeah, so research funding, I myself have been, so DIRH is an NIH-wide study section. And so I think the majority of institutes at this point sign on to the DIRH call. And so you can do it across any of the institutions. I myself have been funded primarily by NIDA and NIMH, and then one study by NICHD. I will say that NICHD is much more, just in my own anecdotal experience, much more naive to the D&I space than NIMH and NIDA are. And so I think regardless of which institution you go to, you want to figure out what their priorities are and where D&I literature or funding kind of falls within their portfolios. We were talking at lunch that NCI is very well funded when it comes to D&I research, and yet at the same time, their priorities are more on the earlier end of the continuum in the D&I space than the implementing in the community setting space. And so it really depends, but there is absolutely funding out there. DIRH gets a ton of applications. Although I no longer sit on the study section, I have colleagues that do, and I hear how overwhelmed they are. So there are plenty of folks that are submitting to that study section and getting funded. D&I, I think all the institutes are starting to put more money into D&I research because they feel like they have already invested so much money in the development of interventions and people still aren't using them. And so I would encourage anybody who's interested, particularly in developing community partnerships, working in communities, working with systems, dealing with stakeholders. If that is something that sounds of interest to you, then I think that there are lots of opportunities for funding and future work in the D&I space. Yeah. Yeah.
You mentioned the importance of involving stakeholders in the
yeah.
process,
Yes.
as well as the importance of the readiness activities.
Yes.
I'm wondering if you had any sort of metric to evaluate what communities would be ready for this type of program, or if there's any qualitative lessons you learned about those types of communities.
Yeah, it's a great question. So there are some standardized measures of readiness. I myself have not found them to be the most useful for the type of work that I do. We absolutely, for our interventions, we have readiness checklists that kind of go through what is necessary to implement the particular innovation that we are working with. And we see that as a working document. And so we go through it at the very first pass with the agencies or the community to find out where they are, where we're getting started. And then throughout that pre-implementation process, we're really chipping away at that readiness checklist so that by the end of readiness, we should be able to say that all of those activities that we have identified as a group as being important for a successful implementation are attended to adequately. So we have one for our own interventions, but there are ones that exist. Brian Weiner has one, Greg Ahrens has one, and so those are folks, and they're pretty short pragmatic measures, but again, they do require a pretty well-established practice. And so I wouldn't necessarily recommend those if you're developing something with a community partner, then I find them to be a little bit less useful. Does that help at all?
Yeah, among the different groups that you've worked with, justice groups and school groups, and were there notable groups that stood out as having higher implementation or sustainability rates?
Oh gosh. No, I don't think, not when I would think about particular service sectors like that sort of cut that way. There absolutely are communities that are more or less ready, but I don't think that I would say like JJ is more ready than schools or primary care. I hesitate to say this, but I'll say it anyway. If anything, I think the most challenging systems to work in are the primary care systems. I feel like those folks, it's harder to get them ready than it is some of these other public serving systems. Yeah. Thank you. Thank you.